Okay, lifelong health promotion for cardiac patients. Some of these things make a lot of sense. They seem easy to do, but patients sometimes are very non-compliant. It's difficult for them to do these things. So, eating the right things, low in fat, that's going to help reduce your um, lipids, as well as they may be taking some lipid lowering medications as well. Exercise helps build up strength in the heart. Exercise promotes weight loss, promotes lower hypertension, promotes lipid lowering, lowers your lipids, stress reduction, does the same thing. No tobacco use. Notice this says no tobacco use, not cut back. Controlling diabetes. If you are diabetic and you control your blood sugars, it reduces the damage done to your arteries. So that's also another thing, plus taking medications and being compliant. So coronary artery disease is the same modifiable and non-modifiable risk factors as hypertension. So the non-modifiable ones, obviously you cannot alter gender, age, ethnicity, or family history. These are the things you cannot modify, but you can modify all the other ones that we talked about previously. So angina, another word for chest pain. You may say angina, some people say angina. I like angina. Chest pain. So when your oxygen demand is exceeded in your coronary arteries to supply the heart with oxygen, then ischemia occurs. Ischemia is basically decreased flow of oxygen. So for ischemia to occur caused by atherosclerosis, your artery needs to be 75% or more obstructed. Somebody with less obstruction will probably not have any angina. So this is why most patients, till they're almost completely occluded, will not notice any symptoms of angina if they have coronary artery disease. So two kinds of angina, stable and unstable angina. So we have something called acute coronary syndrome. Patients that have acute coronary syndrome are the ones that all of a sudden they're having chest pain. They might probably have never had any previous history of chest pain. They didn't know they had atherosclerosis. They may not know they had coronary artery disease. These patients basically are they go to the doctor because they've had chest pain. They might have been mowing the lawn, shoveling snow, raking leaves, doing exertional exercise, and they had some chest pain. Well, they're smart enough to quit doing the exercise or the exertion, and the chest pain goes away. So this is acute coronary syndrome. They may go to their doctor, they may have a stress test, they may talk about things to do and not do, how to eat better. So these patients basically have a notice, the heart has given them notice that when they do certain things, they have chest pain. So treatment strategies for these patients. They may be told, okay, let's maybe give you some nitroglycerin to take if you have any chest pain. Maybe they need to lower their blood pressure. They need to quit smoking. They need to change their diet. These people haven't had a heart attack. Doesn't mean they will have a heart attack, but if they don't change maybe their modifiable lifestyles, they may end up having a heart attack. So all these things need to be looked at, monitored. So treatment strategies, same as the other thing we've talked about. These patients need to watch their control of their glucose if they are diabetic. They need to really be aware of education, maybe cut back on red meat, exercise, get their flu vaccine. We want to do everything so they do not have a heart attack, but they can have a heart attack at some point. Well, so let's say this patient now gets to the point that sustained ischemia causes some cell death. They have a thrombus that forms in that coronary artery, or it builds up even more and they start having a heart attack. So let's talk about MI, having an MI. Cell death in MI, if you do not have oxygen to parts of the heart through the coronary arteries, you will have cell death within 20 minutes. The heart, like the brain does not regenerate its cells. So someone has myocardial infarction, they have chest pain that does not go away, they need to call 911. Call 911 and get them to the hospital. You notice that if cell death begins in 20 minutes, the sooner they can get treatment, the less risk that they will have coronary damage, heart damage. So, relationship of treatment, pathophysiology, diagnosis is all related to whether you will have unstable angina, whether you'll have a heart attack. It also is going to determine lots of patients whether they have an ST elevation MI or they have a non-ST elevation MI. We mentioned last module that when patients have a heart attack, the ST will elevate. Some patients have heart attacks and they do not have ST elevation on their 12 lead, but they're still having a heart attack. So there's two classes of heart attacks, ST elevation and non-ST elevation. So patients having a heart attack, it's chest pain. They will describe this as crushing, squeezing. It's like an elephant sitting on my chest, like I have a ton of bricks on my chest. It won't go away. They may have sweating or diaphoresis. They may have nausea and vomiting. Not all patients, but some do. There will probably become vasoconstrictive in their extremities. So cool, clammy, ashen. They might have pain radiating to down the left arm. Some patients report jaw pain before they have a heart attack. So the pain's radiating to the jaw. Different kinds of symptoms. Difference is, they found out, males and females have different symptoms. If all the doctors for years were male and they did all the studies on males, they came up with classic symptoms of a heart attack. Well, they were only using males as the subject. Males have classic symptoms. Females have symptoms that may not look like the same as males. For example, they may not have the radiating pain down the arm. They may have more nausea and vomiting, maybe a dull pain in the back, or it looks like a gallbladder attack. These are more female symptoms, not male for having a heart attack, but it's still a heart attack. So pain may progress or may not progress to unstable angina or myocardial infarction. So look up in your textbook or Google and find out the differences between male and female in unstable angina or an MI. So MI treatment, this is a protocol pretty much around the country. If you are having an MI or chest pain that will not stop, then you call 911, they come and pick you up. The paramedics will use the same treatment here as they will anyplace else. These are standard treatments. An easy way to remember the basics is MONA. Acronym MONA stands for morphine, oxygen, nitrates, and aspirin. So first thing, they're going to ask the patient, give them some oxygen, put it on, give them some of these things. Have you had an aspirin? Chew a few baby aspirins, if not an aspirin a day. Give them oxygen. The heart needs that oxygen so we don't have any death to cells. Give them some nitrates, nitroglycerin. Put one under your tongue. Does the pain go away? Wait 5 minutes. It doesn't go away. Give them another one. You can give 3 nitroglycerins within 15 minutes, one every 5 minutes. Give them IV morphine. This pain is so excruciating, they need morphine. Tylenol or another pain medication is not going to work for these patients. So this is the basics, MONA, for a patient that's having an MI, or if it appears they're having an MI. So, normal EKG and electrical system. Remember this. You've got your normal P, QRS, and T. This is what it looks like. That QRS to T is basically the depolarization of the ventricles and the repolarization here, the T wave. If you're having a heart attack, basically what happens is you have ischemia and you have that ST elevation. Here's that QRS, here's your T, and what happens are two things. You will have elevated ST elevation right here, And then what happens after a heart attack is you have T-wave inversion. It should be upright on this lead, but it's not. So after a heart attack, you have T-wave inversion, which at some point will resolve. Then you have ST elevation. This is why you have so much pain. This is being caused by no oxygen to heart tissue, ST elevation. If you can open up the coronary artery soon enough, this ST will resolve and go back to normal. So, lab test. If someone's having a heart attack, the death of heart cells will release certain enzymes. They're called cardiac markers. The two most common is CKMB. The other one is called troponin. Troponin is the most accurate. This is the one that is only given when you're having a heart attack. This is pretty death of heart cells. These will peak in 24 to 48 hours. So this is the one that they usually look at, is troponin markers for cardiac damage. Higher the numbers of these, the more extensive heart damage a patient has. Your EKG changes are ST elevation, unless you may have a non-ST elevated MI, and that's going to be ST depression instead. So, problems and issues with MI. Well, the number one thing we want to do is we need to get that coronary artery open. So, problems that we have from an MI is, let's say we can't get that coronary artery open. The patient may have to have coronary artery bypass graft. That's open heart surgery. The patient, because of heart damage, could go into cardiogenic shock. Also, another problem and an issue of an MI is, depending what area of the heart is damaged, you will have a dysrhythmia. It may cause a dysrhythmia in your heart, and that is another issue. The patient may code because of the MI. So cardioversion and defibrillation, those are all issues. But what we want to do is open up that coronary artery. Hopefully they can do it before any of these things happen. So what we want to do is we want to open that up. Well, the best way to open it up is, let's take the patient to coronary catheterization lab, cath lab as it's called. So take the patient to cath lab and we want to open that up. Now, patients having a heart attack, we take them to the hospital. We already did MONA, morphine, oxygen, nitroglycerin, and aspirin, but there's other things we can do as well to open up and treat before we maybe get them to coronary cath lab. We can put them on a nitroglycerin IV. Instead of PO in the mouth under the tongue, we can put a nitroglycerin drip on them. Remember, nitroglycerin will dilate all your vessels, whether coronary or venous. It'll dilate everything. The other thing is we can give them a lot of morphine. We can put them on a morphine drip if we had to. Both of these things are going to lower the patient's blood pressure. So you have to be careful not to give too much, that they're bottoming out their blood pressure and they don't have enough perfusion. The other thing is that we can put them on heparin. If the clot, or if the blockage was caused by a clot, then maybe we can put them on heparin, and that's something that we can do so they don't form another clot, or the clot doesn't get any bigger. Another thing we can do is use fibrinolytic therapy. A common brand is TPA. This breaks up the fibrin in the clot. So if it's a clot that's causing the MI, if we give this medication IV, it can dissolve that clot and open it up for good blood flow and good oxygenation. The problem with TPA is there are a lot of contraindications that the patient has to make sure they meet, or you may do more damage. So it has to be given within a certain time frame, and other issues. Patient should not have had surgery, should not have any bleeding issues, things like that. So we can do more things before we take them to cath lab. So the goal, though, is to stop death of cells. Remember, death starts after 20 minutes of no oxygen. So we can give the fibrinolytics. We can take them to the cath lab, coronary cath lab. Hopefully, when they're in the cath lab, we can do an angioplasty. An angioplasty is where they inflate a balloon and make that coronary artery larger so the blood will flow. We can put in a stent. A stent is a wire mesh that opens up and allows blood through. So a stent could be placed in the coronary artery. If the patient has too many blocked coronaries or it's multiple blockages, maybe a coronary artery bypass graft is the only thing we can do.